requiring integrative oncology. And this integrative oncology involves the nano-based drug delivery system and increased in therapeutic effectiveness, even in cancer-resistant cases. Sorry about that.
If you go up to slideshow, hit that, and then you can get.
That's, yeah, we are fine now, right?
Well, we're still in the making mode. So if you go up to slideshow here and hit that, okay, right here. See where I'm pointing? Right here.
Okay.
Slideshow right there.
Where is this?
Right here.
Here. I'm not able to see your pointer.
Okay. Well, it's right at the top. See
on
where
the right side, left side?
Right at the top. It's it's 1, 2, 3, 4, 5, 6, 7. The eighth one from to the right from the left-hand side.
Are you there?
There we go.
Okay.
That's better. And you should be able to just, yeah, there you go. Okay. Okay.
All right. So this is the patient who had breast cancer, and now we will continue with how she presented and what we have done. So this is the 56 years old white female who came with the diagnosis of adenocarcinoma of her right breast. She was asymptomatic when she presented to her physician. She went for mammogram in 2019. As her previous mammogram had a suspicious lesion, so it was repeated the following year. And review system was positive for the Hashimoto's thyroiditis, as she had thyroperoxidase antibody 900 and thyroglobulin antibody of 569. She was also hypothyroid from age 21 following the birth of her son. And this is not uncommon because pregnancy is one of the very process where the immune turmoil occurs because of the babies in the utero. In 2014, she had a weight gain of 45 pounds, and she developed chronic fatigue, joint pains, neck and back pain, sleep apnea, insomnia, anxiety, high blood pressure, and hearing loss. And she also developed the tremors of her left hand with some spasticity in hand, which she was not able to extend her hand completely. Her MRI of her neck was done and it was negative. CT scan was positive for nerve impeachment, and the nerve conduction.
Yeah, it looks good. It's going to be about 84, 82 on Thursday.
Excuse me. And nerve conduction study was positive for the nerve impingement. Her family history was positive for autoimmune disease. Her mother had a chronic lymphatic leukemia, and she died of the complication of chemotherapy. Her brother was alcoholic, and she did not have much support from the family. Her house, now as we look at her environment, her house had a big problem. All walls in her house had mold, and she noticed that. But instead of having somebody else clean this house, she cleaned herself with chemicals. And then to cover it up, she painted it with the mold preventing paint. Following that, she developed chemical sensitivity because she did it in a closed room, and she did not take any precautions to wear any respirator or anything like that. And currently her basement is damp and musty. So the mold problem was not completely cleaned out. And so mold evaluation was done for the house and found to have a heavy growth of aspergillus and penicillium mold, including alternaria. So she really needed a good remediation for the mold, which she was not able to do for a long time. So now then when her mammogram was done, it turned out to be positive for multiple nodules in her breast. She had a needle biopsy and which showed invasive ductal carcinoma. Her onco test showed a high score of 37, showing that she had a poor prognosis as higher incidence of distant metastatic disease can occur. She also had MRI, which was positive, and PET scan showed that she had a local disease with no distant metastasis, not even into the lymph nodes beyond axilla. So she had her surgery, was scheduled to have completely removal of her breast, mammectomy. But however, surgeon decided to change his mind and told her that instead of removing the whole breast, he's going to preserve her breast and just take the 3 lumps out. So he did a triple lumpectomy instead of total mastectomy. And then he removed 5 lymph nodes, which were negative. So he didn't pursue it any further. Following surgery, she was recommended to have a chemo as she had a stage 2 invasive ductal carcinoma and had a higher onco score. She declined to do either chemo or radiation due to the adverse experience what her mother had, and she died from it. So she did not want to go further with this therapeutic intervention. Following surgery, she came to our center, EHC Buffalo, for the integrative oncology management. Following baseline blood tests, she was provided 16 weeks of oxidative therapy and photodynamic treatment with the photosensitizing agents given 1 hour before and followed by the high density laser therapy, giving her the photodynamic treatment. Then she felt good. All her tests were negative. So she decided to just stay home and did not come for further follow-up visit for almost like 6 months. She remained on all her supplements, including vitamin D and low-dose naltrexone at 4.5 milligram dose. So December of 2020, she had another PET scan at 1-year anniversary date from her surgery. And at that time, they noticed the right axillary and large lymph node. And then on January 2021, she had ultrasound guided biopsy of the same lymph node, and it was positive. So subsequently, she was diagnosed to have right axillary metastatic adenocarcinoma of the breast, and lymph node size was 21 millimeter. So the surgeon's recommendation was do the total axillary lymph node resection, but she did not want to go for this conventional treatment because of the complication. The risk was that she would develop the lymphedema, and she may not be able to use her right hand and right arm. Now we know that she has tremors and a flexion deformity in her left hand, which is completely non-functional. So she returned to us for the integrative treatment. The biomarkers of inflammation were high. Her TGF-beta1 was 24,000, D-dimer was high, and she had also immune dysregulation. We did the RGCC test for circulating tumor cells and sensitivity to different chemotherapeutic agents, immunotherapeutic agents, as well as natural substances. This test also gives the genetic mutations, so that would alarm us if she has a genetic mutation and how she is going to do well or not. These also multiple drug resistance for tumor cells are also measured on this particular test. So following her results, we started her on the treatment. First thing, we started on repurposed medicines. And those of you who do not know what repurposed medicine is that the drugs which are FDA approved for one purpose, they can be used for the secondary purposes. And so we started her on substance like metformin and later on losartan. And we also started on some other nutrients. She was also on oxidative therapy, oxygen ozone treatment, high dose vitamin C with insulin potentiation, and photodynamic treatment. Ultrasound exam was repeated, lymph node size remained same, but she did not have any more enlarged, no new enlarged lymph nodes. And her lymph node was much more localized than was seen in the original ultrasound and CT exam. Subsequently, we decided and we injected methylene blue and exosomes locally in her axilla under the ultrasound guided, and injected the lymph node. 3 weeks later, she was unable to palpate this lymph node, and we continued the oxidative treatment. Meanwhile, RGCC test results came back, and because it takes about 3 to 4 weeks. So we have to start the treatment prior to the results. And once the result came, it showed that she had multiple drug resistance. She was not sensitive to immunotherapeutic agents, for which she did not receive the PD-1 monoclonal antibody treatment, which is usually we give something like Optivo and Yervoy. And then she received the platelet-derived nanoparticle conjugate ultrasound-guided injection treatment to her axillary lymph node. And these platelet nanoparticle conjugates included the platelet-derived nanoparticles. They were mixed with peptide TA1, immunomodulator. Being an immunomodulator, it increases the tumor cell apoptosis and increases the autophagy. And the methylene blue as well as the ICG were used as the photosensitizing agent and for the PD3 treatment. And also we gave the Avastin, which is for the anti-angiogenesis factor. So, and following the injection, we provided her with the laser treatment, which gives the red light 660 frequency and also 810 frequency delivered simultaneously, as well as we were also giving her the shockwave treatment as shown in this picture. Patient received the PDT treatment with sonication by shockwave therapy. And vasodilatation due to release of nitric oxide occurs during this treatment. And the cell matrix stimulation occurs because of the mechanotransduction. There's release of substance P, which is analgesic. And so it is used as a pain gating, which controls the pain following therapy. Also, it increases the cell wall permeability. And this is very important for us because when we are providing the patient with the chemotherapeutic agent, it penetrates the cell wall, goes inside the cell, and then it directly delivers the medicine into the subcellular organelles like mitochondria, and it permeates the nucleus and goes and attacks the DNA and does the DNA destruction of the cancer tumor cells. Not only that, but it also stimulation of the stem cells, which increases the apoptosis and autophagy. Shock waves are transmitted to the site of tumor and surrounding tumor microenvironment. And transmitter tip radially transfers the energy to the tissue that receives the photodynamic treatment. And we had done this very successfully. As shown here in this picture down here, you see that this shock wave given through this head here, we used in this particular case 2 millimeter head. And so when this shock wave in the form of the acoustic wave is transmitted through the surface to the deep tissue, and as you see that it breaks and shatters the scar tissue. Now, the fibrosis is nothing uncommon in the patient, those who are developing the tumor. And that's how the tumor protects itself as it becomes very hard for the therapeutic agents to penetrate the wall. And so the tumor, the chemo agents do not penetrate, and one starts developing the resistance to the cancer therapy. So now, following this treatment, patient has done very well. All biomarkers of inflammation has improved. As you know that in cancer, in the tumor, it is a tug of war between inflammation and between the genetic mutation. So if we somehow reduce the inflammation, it really helps to fight the cause and response of the tumor to the chemotherapeutic agents or immunotherapeutic agents or other agents which are delivered through the special drug delivery system. And as you see here, that tumor growth factor beta 1 came down from 24,000 to 7,300. And other biomarkers for the cancer breast were negative too. Her lymph node size improved, means that it got smaller. She has continued with the oxidative therapies along with the PNP conjugates therapy. Follow-up exam in 4 weeks, we will receive the second treatment. Anyhow, these slides were done before, but we have given her 3 more treatment and she has done well. So we are delivering chemo with PM platelet nanoparticle drug delivery system. And we have guidance from the RGCC test, as Robinson is a good chemotherapeutic agent, has a good sensitivity. So we are using that in a much smaller doses as compared to given as a systemic treatment. Now, this patient, so one may have a question that why do we use the PNP treatment? Okay, so the platelet when during the PNP treatment, how do we provide it? The blood is drawn from the patient, it's heparinized, and then it goes through the machine, and we separate the platelet rich plasma, and then subsequently it is sonicated. So the platelet is broken down into the platelet membrane, and then we are infusing it with all the different molecules we want to deliver to the patient. So it can be chemotherapeutic agents, it can be immunotherapeutic agents, it can be photosensitizing agents like methylene blue, it can be the ICG dye, which is also photosensitizing agents, and we can also give the N-acetylcysteine, which has a multiple purposes when provided, because we do not provide glutathione to any of the cancer patients. But NAC, we don't expect it to be converted into the glutathione in the tumor tissue. It helps as a fibrinolytic agents and also antithrombolytic agents. So the drug is delivered directly into the tumor, and with the sonication technique, we are shockwave technique. Once the medicine is injected with the shockwave, we are dispersing into the tumor as well as the peritumoral tissue. And with the delivering the photodynamic therapy, we are focusing the waves from the laser waves directly, which are the proton laser waves, directly into the cancer tissue, which produces the thermal effect as well as the hypoxic effect, and then try to destroy the tissue. So intratumoral administration of the platelet nanoparticle drug peptide strongly enhances the local immune activation. So once some cells die and the medicine is delivered, and there is a active immune activation, and so it tries to destroy the tissue, so the complete tumor regression occurs, and it provides the protection against the repeated tumor rechallenges, means recurrence. Moreover, treatment of an aggressive breast cancer, intratumoral platelet nanoparticle conjugate delays the tumor growth and inhibits the lung metastasis, bone metastasis, liver metastasis. It just depends what type of cancer you are dealing with. And locally delivering the immunostimulatory loads using the biomimetic nanocarriers, which possess the advantages such as enhanced biocompatibility because it is the part of the body, and natural targeting affinities. Now, one may say that why do you use platelets? Well, because the platelets have a direct affinity for tumor cells, and tumor cells have a direct affinity for platelets. In a regular conventional setting, the platelet helps the tumor cells to metastasize to the different parts of the body. However, when we deliver the platelet nanoparticle drug delivery system, it does the opposite. it is attracted towards the tumor cells, but instead of spreading them, it kills them. So this is very important. So this is the one of the research paper which showed that PNP conjugates demonstrated significant activity against local carcinoma and their ability to release active doxorubicin in tumor. Not only that, but it has a highest cellular uptake and preferential nuclear accumulation of DOX, most cytotoxic, and this effect correlated with the accumulation of DOX in the mitochondria. PNP conjugates increase the therapeutic efficacy of DOX for sensitive and resistant cancers. And resistant cancers have become so rampant, and we get so many inquiries regarding the cancer resistant to the chemotherapeutic and immunotherapeutic agents. So keep in mind that there are other alternatives available. Even if the patient tells you that I have developed the resistance of chemotherapeutic agents, and doctor, how are you going to treat it? Well, the chemotherapeutic agents, we have a direct delivery system. We direct delivery to the tumor tissue. And what happens is in the platelets, these all drugs gets encapsulated, and these capsules are completely attracted to the tumor tissue. It goes in the tumor microenvironment, and it does the release as is shown here. And it not just the release is only in the tumor tissue, but it goes into their subcellular compartment. It goes in their nucleus and then start to knock off their mitochondria. So then there is no more any activity left for the energy production, and then they go and destroy their DNA. So this is a very, very powerful tool that can be used. But you do need the very powerful photodynamic treatment. So you need a very powerful laser which delivers not only the red light, but also the spectrum of 810, which is called infrared lights, as well as a hyperthermia effect, because many of the cells are very thermal sensitive. So they also call the photothermal treatment. And these features are of clinical interest for the administration of the treatment to lymph node in the metastasis in the breast cancer patient, as well as many patients with the ovarian cancers can be treated similar way. Prostate cancer can be treated similar way. And you can do the really, even ovarian cancer patients, we have done the intratumoral injection through the anterior abdominal wall. And we follow that with the shock wave treatment. As I've shown you that the shock wave are converted into the acoustic waves, and then that has a great degree of efficiency. So now this case report is open for discussion. Are you there?
Yeah, Dr. Patel, what is oxidative treatments?
Okay, so the oxidative treatments, we are using the high dose vitamin C, and you know high dose vitamin C. The low dose is the antioxidant, but when we are using very high dose like 75, 50, 60, 70, 75, 200 grams into the IV solution, it becomes the oxidative treatment because it produces the hydrogen peroxide, and the cancer cell does not have the machinery to destroy that, and that becomes the oxidative agents to kill the cancer cells. Now, we also using the oxygen ozone treatment. And as you know that a very hypoxic environment gets enriched with the oxygen made from the ozone, as well as the ozone has a destructive capacity for the killing the cancer. And then we are also giving the hyperbaric oxygen, and photodynamic therapy is also considered part of that too. So there are multiple treatment, and also we do a treatment with the P53 mutation is very common, as this patient had a P53 mutation, and she had a multiple drug resistant gene mutation too. So as we know that curcumin has a great affinity to increase the P53, repair the P53 mutation. And so we are using other agents like curcumin, artemisinin, metformin, berberine. They all help to repair oncogene, tumor suppressor gene, P53. And it also mediates through the other signaling pathways like BAX and BCL2, P22, 21, etc. So you must look into all different things. And not only that, but following these, what we do is we make sure that when the patient's tumor is destroyed, a lot of toxins are going to be floating. So the patient's detoxification system, it does also work. And so we do the sauna detoxification, they do the coffee enema, they do the food detox. We put on the whole body photodynamic treatment. So these all tend to help. And whole body photodynamic treatment, laser treatment has helped the patient. Even the conventional treatment receiving chemo, that what they call chemo fatigue, it works really good for those patients too.
Does insurances cover any of this?
No. And then the minute you say that it is an integrative oncology treatment, it is not covered. And that's why the patient understands when they come to you and they know that we are providing the integrative oncologic treatment, nothing is covered. And we don't take insurance for any of the care provided at our center.
So what might something like this cost, this regimen of yours, a ballpark figure?
The vitamin infusions are not very expensive. It is the vitamin infusion can vary from $200 to $400, $600 for a whole day treatment. But the most the cost, and they are very cost effective. Like hyperbaric oxygen is $100. Photodynamic therapy is $200. They have to pay for the photosensitizing agents. So those are not very expensive. The expensive part is the drug delivery system, specialized, the platelet nanoparticle drug delivery system, and all the agents you are using to process that. And I said we do not take any insurance, but their chemotherapy, if they have a good insurance, we order the chemotherapeutic agents as well as immunotherapeutic agents through their insurance, because they have a CVS mark or some company that processes their medicine for 90 days. So that part is not very, I mean, there are multiple forms to fill out and etc. But that we have done that, because otherwise immunotherapeutic agents are super expensive.
Okay. You mentioned you don't use glutathione.
Glutathione should not be used any patients with cancer.
Okay, the reason being,
The reason being that it is used by the cancer stem cells and it becomes more powerful, and you don't want to make them more powerful because then their lifespan is indefinite, and then their cancer cells go and become the cancer stem cells. That's even very distressing.
what about low dose naltrexone as an anti-inflammatory?
Yeah. I told you that we treated this patient with the low dose naltrexone.
Okay,
Question on CBD, CBN, CBG, and THC. Do your patients use it or try it?
Well,
before
I
they
mean,
come to you?
if they have a problem with insomnia, they have a problem with anxiety, yes, CBD can be used without any trouble. And on the contrary, CBD has been found as immunomodulatory. So, but it cannot be used as a main agent. It can be used as an adjunct. Supportive treatment. I wouldn't say adjunct treatment, but I would say as a supportive treatment.
okay. Anybody else have any other questions on this case?
Yeah, I have a question. You know, like the whole process of giving the patients the chemotherapeutic agents via PMP and the thermo agents as well, it would cause a lot of breakdown in the system. And I know you're doing the coffee enemas and things like that, and the saunas. Like, what else would you monitor? Like, would there be with the cellular breakdown of cells in general, like too much protein in the system? Do you have problems with like the kidneys or
No,
other
that's
organs or
being
stuff like
monitored.
that?
That's being monitored every week. So that's constantly being monitored. Because if you see that any conventional therapeutics, they do monitor it. So we do most of the monitoring the similar way they do the conventional treatment, but we edify it with with doing the adjunct treatment for detoxification. And I did not mention, but we also give the detoxifying drainage formulas. So that helps. We give them bitters, we give them oral curcumin, we give them oral artemisinin, besides giving the IV in between.
Oh, and you know, the PNP, when you're making the concoctions with the
Yes.
with the doxorubicin
Yes.
and the other therapeutic agents, do you then sonicate it and put it in an IV bag and infuse it that way, and then do all the treatments afterwards? Or do you target it in certain
Listen,
areas and then do the?
We give the local treatment first. After finishing everything locally, if the tumor is reachable, okay, like in this patient or in my another ovarian cancer patient. But let's say the tumor you cannot reach and it is in those places, yeah, of course you put it in the IV bag and then they get as an infusion. Even when we treat locally, we give them, because we don't know when these patients are going to develop the metastasis, at a distant metastasis. So we usually give them treatment that way too.
So both ways,
Yes.
locally and also via IV?
Correct.
Okay.
Sometimes we give locally at one visit and peripheral at the another visit. Depends upon how the patient's tolerance is. Because sometimes if you do overkill, then they have a bad Herx reaction, and you don't want that experience. We had one patient that we gave that treatment, and then she developed severe pain, and we knew that she was killing that. And usually you require very, very powerful pain medication to do that. So the following treatment, we gave her the oxycodone to begin with, and then we did the treatment and it went just beautifully.
So you also preemptively treat the pain ahead of time.
Yeah, you have to, because you know, you want to make, they have come to you for the as natural treatment and as comfortable treatment possible. So your each patient is going to be your challenge, and that challenge, how beautifully you control it, that and manage it, it matters. Because you know, you consider it is your family member and you're treating your family member, and keep as much compassion and love for them for their healing.
The other question I have is, you noted like ozone treatment in the system. Are you ozonating the liquids or the IV infusion?
We are liquidate. We do not put in our PNP delivery system, but we do draw the patient's blood and we ozonate the blood, and then we pass it to the photobiomodulation light. So we are giving the dual treatment. So, I mean, you know, we have to oxygenate the patient. That's why we start our day with when patient comes, patient goes in a hyperbaric chamber. After hyperbaric chamber, either they get the photobiomodulation, ozone oxygen treatment with the photobiomodulation. Then they get the vitamin C IV, and before that, we draw the blood and prepare the PNP. So at last they get PNP, a treatment locally, because it takes about over 2 hours, between 2 to 3 hours to prepare it.
So the treatment basically takes like a half a day.
Oh, more than half a day. They come at, because when we say we give 1 hour of hyperbaric treatment, usually, you know, there's a 15-minute of downtime in the beginning and later, so it becomes an hour and a half. Then when you're giving ozone oxygen treatment, that takes about more than an hour. Then vitamin C takes and by that time you have already drawn the bloods to prepare for the PNP conjugate treatment. So at that point, it you know, the clock starts ticking for that treatment while you're also delivering the vitamin C treatment. And we do hydration, we do good degree of hydration. We give about 1,000 cc of fluid at that time. So whenever we have noticed that, we have to have a good hydration. And if we do good hydration, patient is able to tolerate it better. But when we use the PNP treatment, we do not give the insulin potentiation for the vitamin C treatment when we, otherwise we do that too. But PNP works very good. It has a special attractiveness for the tumor. So you really don't need insulin potentiation for that, because with insulin potentiation, blood sugar goes down and just patient goes through the rough time for a while before bounces back.
Have you had any success with either primary or secondary liver cancer? I have a 48-year-old female with stage 4 cervical cancer that has dramatically metastasized to her liver. So I'm wondering if any of these alternative treatments might be helpful.
I have personally started treating the patient, but unfortunately, patient was receiving the treatment at Roswell Park, which is our big cancer institute in Buffalo. So they said that he came and we started him on oxidative treatment. And I said, you do need PNP treatment. He said, what doctor, what about if I finish these 2 treatments and then we start? I said, no, I don't have any problem with that. And you know what? They killed that patient.
Huh.
I mean, I was just so sad about that. It was such a vibrant. See, I have never felt so good after I gave him few oxidative treatment and oxygenation. He said, I have never felt so good in my this particular during this process of my cancer. I have never felt as good. And then, after 2 weeks, he didn't show up. So we did not know, and nobody answered the phone. Then my office staff found out that he passed away, and I was so sad because he was such a vibrant man when he left my office.
They tried to kill my father.
Yeah, I mean, each one of us we know, but I mean, this is so fresh in my mind, and it just breaks your heart. But that's how this is a beast. When we are dealing with the cancer with metastasis, it's a beast, and we have to keep on trying and keep on trying, because we cannot say, okay, you come, we give you treatment now, and then you come in 2 weeks. We cannot do with that. Otherwise, their markers will go up for sure. Because by the time they come to us, they're already, they have, their conventional physician has already checked them out and then say that, do you need a hospice care? So we have to understand that we when we take on the patient, we don't take on them in the as good condition as their conventional physicians have done it. We get them at the last stage.
Yes, you're right. And it is very emotionally sad.
I mean, I tell you, I those days now, I do not, the days I treat those patients, I do not see any patients until after they leave in maybe 1 or 2 hours. I just take myself to relax completely, because it is so, you get involved in that, and your stress hormones always on work. You say, you're relaxed in front of patient, but inside of you, your stress hormones are working. So yeah, I mean, I think, what does that patient have? If the patient have the finances, you should try to do everything, because we don't know which patient is going to have 100% outcome. And if the liver, you can ultrasound, and if the tumor is right on the surface, you can give chemo right, intratumoral injection, and follow by the shockwave treatment. But you have to use the different frequency, different energy, and different round, and how many you deliver. It requires some experience, but it can be done, because each patient is different. And I treated stage 4 breast cancer patient with the metastasis in her abdomen and some in her liver, and I have completely cured her. In 3 years post, she has remained completely negative PET scans and normal. So that patient was told that now you have a few months to live, and just have all your things in order, and if you are in pain or anything, let us know, we can get hospice for you. So I'm just telling you that even if you get patient in that conditions, if you are persistent, you can make a difference. And in that patient, I gave her the allocyte stem cells, and I gave her like 4 vials. So each one was like 25 million count in different times. And I gave hours of photobiomodulation. And also I used on her just to enhance her energy, some NAD/IV, so that helped her too. So do whatever you need to do, because you have to get rid of the tumor, you have to improve the genetic mutation, because you can repair it and make that tumor suppressor gene very aggressive, so it can fight and downregulate the inflammation. then you can really proceed further.
Thank you for your passion, dedication, and feelings.
You're welcome. So I hope this case presentation help each one of you to be proactive for your patient. You know where the help is available. It's not that all of us are doing the same thing. You may be doing one thing, I may be doing other thing, but it certainly, it helps. We cannot take hope away from them.
One more observation. I don't know, Doc, if she knows about, do you know about Dr. Forsythe here in Reno, Nevada?
Dr.
Dr.
Forsythe in Nevada? No, I
Yes.
don't. Uh-huh.
He's doing some of the same protocols that you're doing, and he's saying he has roughly a 70+% success rate with stage 4. And he's even entered some more nutritional therapies and been doing this for a few years now. And I believe if you guys work together or compared notes, it might help both of you.
Well, it would be nice if you have a phone number. I'll be glad to contact him, or
I
you
have
have
it.
my-
I can get it for you.
okay. So you can let him know what I am doing, and I'm open. Whatever I can do for my patient to help them. There's only one life to live, and if we can give somebody some hope and some life and some good years to live, there's nothing more than what we can give somebody a gift.
Amen.
Doctor, you're in the Buffalo area. What happens if a patient comes, let's say from New England, and because of the extent of the therapies, is there places that they rent for a while? And
Yeah, we do have a place, and if we let them know ahead, there are certain B&Bs around us, and which are electromagnetic free, because I'm a specialist in environmental medicine, and I wrote 5-volume books, so work for 40 years into that field. So we want to make sure the environment is safe, mold free, chemical free, and they can get easy access to the good food, and we have a whole food. We have a lot of good shops where they can get their food, and B&B. My other patient says that it's very safe, but I have some mold sensitive patients, those who come for treatment from New York City and wherever there's a large amount of moisture and mold, and they prefer to go to that few Airbnb. Some patients coming from Boston, they also, and not too far from our office. So even if they have a car, very good. If they don't have a car, even Uber can bring them.
thank you.
So are we ready for second case?
We're ready.
Okay, great. So this is an unusual case. This is a 31-year-old white female, and she came with the recurrent symptoms of open wound on top of both hands and painful ulcers, swelling of both hands, and last 3 years duration. These ulcers on her hands. And 3 years ago, she developed swelling of her hands first, then the few bubbles developed, and those bubbles turned into ulcers, and they progressively got worse. She saw many physicians, including vascular surgeons. She had many blood tests, wound cultures, Doppler, which showed a normal blood flow. She was on many antibiotics without significant effect on healing ulcers. The skin biopsy showed acute and chronic inflammation with exuberant amount of granulation tissue with fibrosis, suggestive of stasis ulceration on dorsum of her hands. MRI of upper and lower extremities was negative, meaning there was no osteonecrosis. Blood test showed ammonia level of 72. A normal level reference range is 0 to 40. But 2 weeks later, it was normal. IgA 145, IgM 151, IgG 884, which was essentially normal, IgE 47, but vitamin D was very low, and TSH was 1.53. Hepatitis A, B, and C panels were negative, and HIV was negative too. However, she was positive for anti-cardiolipin antibody, and the Saccharomyces cerevisiae antibody IgA was positive. Coagulation factor 7 and 8 were negative, and her review system showed fatigue, weight gain of 30 pounds, muscle pain, weakness, lower extremity edema, no history of easy bruising, anxiety, or depression. She has a premature ovarian failure, as she used the depot shot for 12 years. And after she removed it, and she had no periods and hormone levels remained low. Her past history was also significant in swelling of her lower extremities, lower part of both legs, lymphedema of both feet, swelling of upper extremities, hands, and forearms. She smoked since age 12, 3/4 pack per day, and stopped for last 12 months. But anyhow, she's vaping now. So she is a heroin abuser since age 17. She stopped during pregnancy at age 18 and had a child at age 19. She was injecting in her arms on and off for 3 years duration, but none currently. That was at least for a year. She did not have anything. Alcohol abuse intermittently. Diet was low carb, more vegetables and fruits. Medicines were Xanax, Lexapro, estradiol, Bactrim, Proxetil, and compression bandages. And she was also taking vitamin D as a supplement. She tried multiple antibiotics. She was on Augmentin 875 milligram twice a day, vancomycin. Family history, she had a diabetes type 2, her mother, and hypertension. She has a son, who is 11 years old and fairly normal. Physical examination of the patient revealed she was morbidly obese. Both hands were swollen. They were reddish blue in color. Dorsum of hands had discord-shaped wound with well-demarcated margins, deep wound with exuberant amount of granulation tissue, larger on the right hand than the left, metastasis in hands with desaturation, and bluish tinge to the hands. Forearm was swollen too, more near elbows than wrist, and more pitting edema, suggestive of lymphedema, and lower extremities swollen more in thighs and upper part of the legs below the knee joint. And this is what I saw. Have you ever seen something like that?
No, that looks scary.
Yeah, it was very scary. But as I described it, I mean, this is the super granulation tissue and necrotic tissue and very well demarcated. And here it was not as bad. And I said, how did you do it? And all what she does is put the Telfa pad on it and then compression bandages. And she moves around. So as I described it, it was a necrotic wound, 7 to 8 centimeters, left hand 4x4, swollen extremity, lymphedema, hands, forearm, feet, morbid opacity, and patient was ordered to have blood test and to return in 2 to 3 weeks. So what to do next? So what I did was I sent her to the hyperbaric, a high pressure hyperbaric, because a low pressure hyperbaric would not work for this patient. And because she had a greater degree of hypoxia, and a vascular surgeon who can debride and check the oxygen tension in the tissue around, and then decide that what pressure she would require. Probably she would require anywhere between 2.5 to 3 ATA of pressure in 100% oxygen, which I don't know. She never showed up, but this was an interesting case, which I have never seen in my over 50 years of practice. So I thought it was worth showing it. And what did I find? That whenever somebody is doing the heroin abuse for a longer period of time, they develop usually the leg ulcers, and they develop because they use and inject the drugs in their veins. People with the history of drug abuse are at the risk for the venous disease, leg ulcers, especially if they inject in the femoral vein. Similarly, one may develop ulcers on the back of their hands when drug is injected into the antecubital area veins. Leg and hand ulcers may develop long after drug use, and maybe after many years of ceasing the drug use. And that was the one home-taking message was for me, that it can be done. For many years ago, and they might have discontinued for years ago, but this is what happens. Not all ulcers are venous, some are arterial, and comorbidity exists. So heroin may be contaminated with the microorganisms introduced during manufacturing process, including spore-forming bacteria like Clostridia. And prevalence rate is 15%, which is very high. And leg and hand ulceration is considered end-stage venous disease. And people who inject below belt in groins, legs, and feet are at increased risk of developing venous disease. Chronic injection use includes scarred and collapsed veins, bacterial infections of the blood vessels, abscesses, and soft tissue infections. And many of the additives in street heroin may include substances that do not readily dissolve and that it results in the clogging of the blood vessels. And many times the menstrual cycle also become irregular. And now we can just see that looking at this lymphatic system chart, if they are going to have an injection given in their groin, then they are going to have the stasis in their lower extremities. And then between the artery and vein and the venous system and the lymphatic system, it just gets clogged and one develops the problem. So when the drugs are continuously injected, it can lead to significant scarring in the venous and lymphatic system, which we saw that this patient had it. And both systems are affected, venous and lymph, then the lymphedema is present, which this patient had also in her legs. Scarring facilitates the development of blockages in lymphatic vessels. Compromise with the lymphatic system function develops and results in accumulation of the lymphatic fluid in the soft tissue. Lymph can build up when the lymph system is damaged or blocked, it usually happens in the arms or legs, as we saw in the previous picture. So now what would be the treatment plan for a patient like this? She stops smoking, no alcohol, and no any other drug use. Paleo diet, clean habits, nutrient, high dose vitamin C to bowel tolerance, omega-3, vitamin D, B complex, magnesium, and zinc. These patients are nutritionally very, very depleted. So we had the test done. Unfortunately, we did not get the results back. And boost their immune system because that is knocked out too. So if this patient would have come the second visit, I would have used the methylene blue spray, 1 to 2% solution to clean the wound, and then apply the methylene blue gel and given her the photodynamic treatment, which would have helped her the infection, whether it is a viral infection, whether it is a bacterial infection, or if it is a fungal infection. Methylene blue works against each one of these 3 infections. Photodynamic treatment also helps to kill the microorganisms by generation of the reactive oxygen species, and it augments the autophagy. Now we know that methylene blue is a redox agent, so it helps to increase the oxygenation of tissue by itself. And photobiomodulation treatment helps the nitric oxide release and increases the local ATP production to augment the cell defense mechanism. Now, platelet lyset can be also, you can make, and nano solution can be sprayed on the open wound. In my another patient, what I did, I made this platelet nano delivery system, and in that I encapsulated the antibiotics along with the photosensitizing agents, and I added a small amount of NAD in it, so it would dilate the blood vessels. And patient had a very good response. So this patient can have just a plain platelet lyset nano solution, and you can spray them, and that helps in healing. Hyperbaric oxygen, I wrote here 2.3 ATA, but you can deliver up to 3 ATA to oxygenate the tissue because they have a greater degree of problem with the capillary perfusion. Depending upon the response, therapy can be modified. So shockwave therapy, not in the beginning, but later on, you can give the shockwave therapy around, not in, but around that ulcer, because it increases the microcirculation, vasodilatation, cell matrix stimulation through the mechanotransduction, and release of substance P for pain gating, increase of cell wall permeability, so that it will soak up all the ingredients that we want to deliver. It stimulates the growth factor, neovascularization, cell proliferation, and stimulation of the stem cells. So shock waves are transmitted to the site of pain, and surrounding transmitter tip radially transfer the energy to the tissue. So it's a very good step. As I showed you before, that it breaks the scar tissue, shatters it apart, increases the oxygenation, and transmits the energy. Okay, now this case is open for discussion. That I presented mainly that how this case happened to be this bad case, but if you have an open ulcer like that from X, Y, or Z reason, how would you treat it? And that was also one of my reason why I wanted to present this case. So let's say you have a 90-year-old mom and she develops the ulcer on her heel or on her back of her ankle. What would you do? How would you treat?
Anyone?
Well, since I don't have access to all those different modalities, usually if there's a rash or an ulcer and I don't know what it is, say I'm seeing them in the emergency room or something, I'll just put gentian violet on it, because whether it's a fungus, a bacteria, or whatever, the gentian violet should help it, and probably isn't going to hurt.
Okay, so let me tell you, my mom, she's 94, and she usually as they age, the skin gets thinner. So in the bed, when they lay down, that is the part which gets into the contact with the bed, the linen. So she told me that she has a small irritation, and when I and so we treated similarly and put the Band-Aid so that and small dressing there using the Telfa pad and some 4x4 stacked up, and so that she would not rub. But anyhow, she developed an ulcer there. Now, this ulcer, in initial phases, when it occurred first time, I gave the BPC injection around the ulcer. And I treated BPC in the bed. And it took about little or within 10 days, she completely healed. Now, so I was very happy. The second time it happened, and again in the same place, same thing. And you know, I mean, we think that the injection is not very painful, but the amount of pressure what I had to exert to give her injection, it was painful for me to give her. I mean, you know, even though I applied the anesthetic agents and all that. So then we had to think that what else can we do? So we had a nitro ointment and we mixed it with the methylene blue gel and made it the concoction. We put that on her ulcer, and then I radiated with the red light. And in 2 weeks, between 2 to 3 weeks, on a daily treatment exposure, it held beautifully. And now at this point, I think her skin is even thicker than was before. So I think this is one of the things that you can keep in mind, not very invasive, but still you can have a methylene blue gel. You can get it from the Amex pharmacy. You can get but because gel is very important, you can so mix the nitroglycerin ointment in these both. And what I did was I just took the equal part of each, and I just applied that on her, and the light, and after that we put the Telfa dressing on her.
Thank you, Dr. Patel. You know, I wanted to make a comment, and I want you to know that I really appreciate you diving down and giving all the mechanisms of action of all these things. I found that very helpful and very enlightening. Thank you very much.
Thank you so much. I mean, well, my aim is to take message home and mushroom it and treat more patients and give them the relief, and then we have accomplished something.
Agreed.
Yes. Okay. So any other question?
Carry on.
Okay, all right. So this is the last case now. This is the case where this 13-year-old boy who came to my office for evaluation of probable Lyme disease, has no other diagnosis, fits him and needs diagnosis to be treated correctly. He complained of developing symptoms precisely, mom said, on 1/6/21. Nerve pain in feet and legs, developed and very painful, 6 to 9 out of 10 scale. Bottom of his feet and top of his feet were very painful. And there was a numbness on top of his feet and legs developed on 3/17/21. So about 2.5 months later. On January 6th, he went to ski and had a nice time. On his return, he complained of pain in both feet. It progressively got worse with time. He had stabbing pain in the bottom of his feet. Intensity varies as it was excruciating on some days and was unable to walk. He's unable to walk in the morning for about 1 hour. He has to crawl out of his bed, also crawls to his bed as pain gets worse in the evening. When he walks, he limps as he experiences more pain. There is weakness in his muscles. Pressure on his feet gives him burning pain. He has dull aching pain on the top of his feet, and he has a numbness over both legs below knees. So in review system, there was no fatigue, no headache, no migrating joint pains, no history of tick bite, no anxiety, or no depression. Past history, he had plantar fasciitis since age 9, but was good for some time. He was seen by multiple physicians, including many neurologists, and had multiple tests done. And he was my out-of-town patient. His nerve conduction and EMG were normal. They were repeated again, and they were normal. Small fibers, the skin biopsy for small nerve fibers was also done, and there was it was normal, but there was some question about normalcy. So then they did biopsy from different places, and it was negative for small fiber neuropathy. Genetic testing for neuropathy was normal. MRI brain and spine was normal. Spinal tap to rule out MS was done and was negative. However, he received a steroid infusion over 3 days, May 21st, so about 2 months ago. He did not notice any improvement, if at all, maybe little. Blood tests were normal, including autoimmune and immune tests. He continued with pain and problem with walking. On physical exam, he was a 13-year-old overweight young male, low affect, came in accompanied by his mother, limping. He participated in recalling events, those cognitively he was normal. Exam was normal except for the following items. His knee jerks were 3+, ankle jerks 3+, clonus was inconsistent, and feet were swollen. And bottom of his feet red from toes to heel, and tender to touch, painful without touch, skin scaly, top of the feet reddish appearance and hypersensitive, top of the feet reddish appearance, hypersensitivity, and Babinski was negative, but I cannot 100% because he was not able to do the test correctly. Medications, gabapentin 600 milligram 3 times a day. And I asked whether does it help. Mom says it does make some difference, doesn't help him completely, but if she doesn't give him this medicine, then he is more miserable. So there is some improvement with that medicine. He was taking nortriptyline 20 milligram per day and diclofenac 50 milligram PRM whenever he has a pain which gets worse. So his assessment was the feet and leg neuropathic pain and plantar fasciitis and whatever else. So here we had to answer. So is it the complex regional pain syndrome, or what we used to call RST? If yes, why? Well, on January 6th, on further inquiry, mom mentioned that his shoes were tight and he started having problem after this skiing trip. He developed allodynia and hypergelsia. 15 to 50% of the patients with neuropathic pain has this symptom. Allodynia is a pain due to stimulus that does not usually provoke pain. And hypergelsia, increased pain from the stimulus that usually provokes pain, are prominent symptoms in patients with neuropathic pain. These symptoms peripheral neuropathies, and it can be also from the central pain disorders. Allodynia and hypergelsia are classified according to the sensory modality: touch, pressure, pinprick, cold, and heat, which used to elicit this sensation. Peripheral sensitization and maladaptive central sensitization contribute to generation and maintenance of these conditions and reactions. Pain intensity and relief are important in the treatment outcome in these complex patients with the pain syndrome. So then the hyperexcitability of sensory neuron in dorsal root ganglion occurs, and patient experiences these and have a more complex than it is previously appreciated, this particular pathway of dorsal root ganglion. Also, the short fiber neuropathy is characterized by the damage to unmyelinated C fibers and thinly myelinated delta fibers, as indicated by quantitative sensory testing, and the degeneration of intraepidermal nerve fibers in the skin. So this sensory neuropathy is also not uncommon. So consistent with the selective involvement of the small diameter fibers, the clinical presentation of SFN is characterized by a combination of pain, sensory deficits, and autonomic complaints. Small fiber neuropathy can be associated with multiple diseases such as diabetes, autoimmune disorders, but is also idiopathic in a substantial proportion of the patient, approximately 50%. So complex regional pain syndrome, also known as a reflex sympathetic dystrophy, describes an array of painful conditions which are characterized by spontaneous or evoked regional pain, seemingly disproportionate to the degree of any trauma, seemingly disproportionate to exposure time of trauma, usually starts in a limb. And can you see this picture nicely? I cannot enlarge that. So what it just shows that these are the sensory terminals, and these are the efferent fibers. Any physical stimuli, it goes there and it goes to the capillaries, also receives that stimulus, and here the prostaglandins, and they also play a role. Anyhow, peripheral nerve sensitization is the basis of pain and tenderness. So then it CRSP manifests as extreme pain, which is unprovoked. It is spontaneous, and it can be constant or it can fluctuate with activity, excess or prolonged pain after use of contact. Their swelling can be also there, change in the skin temperature, skin color, and swelling of the affected limb. Changes in the skin texture over time occurs because of the insufficient delivery of oxygen and nutrients, and it can cause skin in the affected limb to change the texture. In some cases, it becomes shiny and thin, and while in other cases, it becomes thick and scaly. Stiffness in affected joints occur, and it leads to a reduced flexibility of tendons and ligaments. Tight ligaments or tendons, sometimes rub, pinch nerves, provide an internal cause for CRPS. It is associated with excess bone resorption. So we have to be very cognizant of this fact that even though pain is there, swelling is there, skin temperature can be high or low, stiffness can be associated, local pain may be more one day, less another day. One does more activity on one day, less activity on another day. And it just goes on and on. So muscle strength gets impaired, movement gets impaired, and they do not have, and the history is very, very shallow. It does not give you the complete details of direct injury to the nerve fibers, which controls the muscles coordinating the muscle movement. Oh, I just sprained my leg and this happened. I had another patient who sprained ankle, and she was on the walking boot, and at night she was allowed to take her walking boot off. And next morning she woke up. This is only 9 years old girl. And she woke up and she had extreme pain, and she is living with that pain. So we have to be cognizant that we don't need a severe trauma like some of the our veterans are experiencing. It can be very minor or no history of trauma. Reduced ability to move the affected part of the body. There's excessive inflammation, poor circulation, abnormal movement in the affected limbs, and fixed abnormal posture like dystonia can also occur. Tremors can occur, jerking movements can occur, and secondary spread of disturbed neural activity to the brain and spinal cord can be simultaneous. And so it can affect one limb or more limb. And 35% of the affected people report symptoms throughout their whole bodies. So there are two subtypes exist, and poor circulation can impede nerve and tissue healing. When skin blood vessels overconstrict, the skin becomes cold, white, gray, or bluish. Muscle and deeper tissues, oxygen level also is deprived, and nutrient levels are also deprived, which can cause the muscle weakness and joint pain. CRPS develops only in limbs because circulation is constrained there. Arterial blood pumped down to the hands and feet must fight gravity to return upwards in the veins to the heart. C fiber damage can impede this, permitting blood fluids to remain in the limb where the swelling and then further blocks, and then blood flow return is impaired. Slow circulation impedes delivery of oxygen and nutrients needed for healing. Now, breaking the cycle by reducing limb swelling and restoring circulation is often the key that permits the recovery to begin. So what is the diagnosis? Sometimes all tests remain negative. History of progression of illness is very important. Skin biopsy for small fiber may be negative, but does not exclude functional deficits, as channelopathy can still exist, resulting in allodynia. So what did we do? Now, before this treatment, let me tell you what happened. This mother brought this kid to me for workup for the Lyme test. So although he did not have any history suggestive of Lyme test, I performed the comprehensive Lyme test, which by 3 different methods. And his Western blot was highly positive. So you can never say that, no, if parent feels that kid needs the test, even though you don't think that there is a great chances of it being positive, go ahead and order the test, because you can be at times wrong. And so I started this child on the antibiotic treatment. Not only that, but I started him photobiomodulation. He tried the lidocaine, ketamine, methylene blue before, did not work. Nitro paste, we did not try because he was not feeling comfortable about feeling dizzy, because that's one of the symptoms he can experience. And what we are doing is now we are giving him the Cura laser, which is a YAG laser. And this laser helps with the musculoskeletal injury as well as for the neuropathic pain. So we are doing this almost on a daily level. Initially, he felt much better after 5th treatment, but now we have not noticed much difference, because when he feels good, he does more activity and then he comes back to ground zero. And we have repeatedly told, but we still have it is a 30 treatment cycle we have to do. So we are going to work with him and see where we end up. But any of you have treated patients with this type of problems, and if you have any pulse to share, please do so.
It's been widely reported that low-dose naltrexone can be highly effective in complex regional pain syndrome.
I have started that. I did not write, but because just like I did not write about his Lyme treatment. I started him on 3.5, and then he's still on 3.5. So maybe he tolerated that dose. So we may go to 4.5.
You didn't talk about his diet.
We made all, because once he had a Lyme diagnosis, we started him on our gluten-free, casein-free, yeast-free, sugar-free
Good. Yeah.
diet, and 4-day rotation. So he's not eating the same food every day. He has lost some weight, but because even though he eats less, he's not able to move much. So we have not, usually most of our patients, they end up losing some weight.
You think he cheats on the sugar? He's a kid.
No.
Okay.
Because mom is very particular, and he knows that with the antibiotic, if he does, he can end up getting the Clostridia infection.
The elimination of all artificial sweeteners.
Yes. We have a pre-printed protocol type of sheet, so we just give them. So you're right. They cannot have any sweetener in any form except stevia. I give them stevia.
Any issues with heavy metal toxicities?
I have not checked that because there's no history of exposure, but I mean, you know, if because of his neuropathy, that's what you're thinking about?
Well, actually, can I tell you a little story?
Okay.
I came from Northeast Pennsylvania, which is a coal mining country. There was a very nice sort of middle-class community built right on the outskirts of Wilkes-Barre, Pennsylvania. You know, middle-class homes, nice neighborhood. And within 10 years, a lot of kids started getting very ill. Some of them, there were like 3 brain tumors within a 6-block area. There were a lot of kids with these kinds of, you know, pain syndromes. Some of them had eye problems. And, you know, it was when you see 1 or 2, you know, individually, you don't kind of put it together. But when you start seeing a cluster like that, I started wondering what could be going on. So we got, you know, we did some heavy metal testing on them. We didn't really come up with a whole lot, but one day we had a kid show up with a very like unusual skin rash, skin infection, and I didn't quite know what it was, but it looked to me like some sort of like you know, ringworm fungus kind of thing. And so we sent him actually to he ended up at the, long story short, at the Mayo Clinic, and it was a very unusual, like very rare fungal infection. And so they sent out they went from the Mayo Clinic. They called the Pennsylvania Department of Health, and they went out and they tested the soil there, and there was extremely high levels of mercury, cadmium, and arsenic. You know, and it wasn't really something that I thought of, but it was in this. It was so that those homes were built over these abandoned mine shafts. And you know, that was, and I'm not certainly not suggesting, but I always, when I see something like that, that always comes to mind. You know, it kind of rings a bell. So
yeah, we can do that. That's no problem. This kid is so chubby, does not have any weight. I would have given him some IVs already. But that's something, when he comes next time, I can let the mom know that maybe something may be helpful.
I'm just, you know, again, I just throw that out there.
Then I told her that if he does not improve on oral antibiotics, we may have to give him a trial of IV antibiotic, and he may need a PICC line for that. Because, you know, when it is a neuro-Lyme, you cannot, and can neuro-Lyme coexist with the CRSP? Answer is yes, because it is 1 + 1 is not 2, but could it be 20 or 200? So they can develop the sensory neuropathy, they can develop the motor neuropathy, they can develop the multiple sclerosis, they can develop the plantar fasciitis. So they can have anything.
Okay. Anybody else have any
Thank
questions?
you for your suggestion.
I could just add one thing.
Please do.
It's a German-based technology. It's a pulse electromagnetic field therapy, but it's resonance-based. There's high Gauss and low Gauss. But this has been very effective for the local pain, but also something that they can sleep on at night, and it supports any regenerative cellular therapies. So particularly with feet and leg pain, we've had great success. That's something that you may want to consider. It's a QRS technology.
Do they have a home model or anything?
Well, I mean, as you explained, it depends patient by patient, but in general, in combination therapy with other therapies, it changes the science in Germany has shown. They have 4 patents on the technology. It changes the IO function of the cell membrane. And as a result, everything begins to transform and improves circulation, and certainly.
I do have that in my office. I may tell that when he, after before he gets his laser treatment, he can probably get that. It's about half an hour treatment.
So which technology are you using?
I'm using, I have the mat and I have the other unit. So you put that wherever they have a problem.
Okay. Yeah, that can be helpful.
Okay, anybody else
These
have any?
type of cases are very challenging cases. So I was a little bit surprised that the topical cream just didn't do anything for him.
Well, that was, you know, the impetus for the suggestions to look, to look at some other, maybe a couple things outside of the box.
Right, exactly.
And make sure on the PMF you're using the,
And we gave him the
High
TB4
Gauss center.
peptide too. I'm sorry.
You gave him
We-
which peptide?
TB4 and BPC.
Great.
But
Okay. Well, Dr. Patel, this was unbelievably informative and complete. And we can't thank you enough for your being here and your presentation. And I see there's even a heart popped up here for you.
Thank you.
So thank you all. I know we're running almost 2 hours,
Yes.
which is nice. It was Dr. Patel. Let me give her a thank you so next week we have Dr. Burgess is going to be speaking on neurotherapy. And
Wonderful.
David, make sure you're around because you'll probably be able to jump in on that too. Okay.
Thank you and have a nice
Thank
day.
you. Thank you
and
so much.
nice
Please let
evening.
us know where Dr. Halasa is. Like he seems to have can't seem to find him. So
He's just jumping from one place to
yeah,
another.
I know. All right. And before
He's a
everybody
kangaroo
goes,
these days.
Dr. Burgess is, our chair for OMED, which is coming up, and we have to have a preliminary program in place by next Monday. So if you would like to present anything, we're putting together a program. It's at least 2 days, probably 3 days, about 8 hours, 6 to 8 hours a day. And we're working on doing it as in mini courses on our strengths. So one would be rheumatology and autoimmunity, of course, chronic pain and integrative oncology, hormone balancing. And we have what I'm just calling it's kind of a grab bag. I'm calling it practice management. So we have Dr. Cruz, who does a physician burnout. We have the financial people from Chicago who are always very generous to us. They talk about your financial stability. So we do have those.
Who's doing the integrative oncology?
Well, at the moment, we have Dr. Halasa is one of the volunteers. If you'd like to volunteer, we'd be more than happy to have you. It's a hybrid. It's October 22nd to 24th, and it's in Phoenix, Arizona. It's live and online. So if you don't want to travel, you can certainly.
Yeah, I can do
arrange that.
online, then I'll be glad to do it if I can do online.
Are you still here,
Because-
Dr. Burgess?
Yes, thank you, Dr. Patel, for offering.
Here's our chair right here.
Yeah, and I
Wonderful.
did have one question because it's come up a couple of times, and that is with your treatments, do you use homeopathy?
Yes.
Oh, okay. So that's part of the practice, yes?
Well,
Because some,
yeah, I use the formulas, okay? I use the drainage formulas and sometimes detox formulas, sometimes bitters, but like naturopathy, homeopathy, whatever can help us to improve their health. I mean,
yes, but-
I'm just not conventional.
someone asked if you knew Dr. Forsyth, and two of the things that sets him off is his use of homeopathy, and also he uses poly-MVA. Are you familiar with that?
Yeah, yes, I use poly MVA maybe around 30 years ago, okay?
Okay.
And poly MVA, I did not see a good, I mean, that much different results. And then came the FDA, and then I just thought it is better to stay away from that, you know, because the New York State was becoming a little ugly at that time. So I decided to drop that because it was not giving me any excellent results. Like, you know, the curcumin and the artemisinin, they really have a good effect to work on both parts of the inflammation as well as the genetic mutation. So we know that how we can improve that.
Thank you very much.
Hi,
Okay. Dr. Mojillo, you raised your hand.
yes, Mojo. How-
Okay.
For homeopathy wise, there's a couple of medicines that may be useful for nerve pain. I'm going to put the names in the chat, but Calmia latifolia, that's for pain that goes away from the spine. So it starts in the spine, goes away from the spine. And hypericum is the pain that goes towards the spine. So I'm putting it in the chat so you can check it out and see if that may be helpful for your patient.
Thank you.
Okay,
And
thank you.
they may use it 1 to 3 times a day, depending how they feel, and they can use it as needed. And there's no drug interactions or anything like that that we need to worry about.
Terrific. Thank you.
Okay,
Thanks.
thank you so much.
Thanks for the presentation. It was very interesting.
Thank you.
Okay, Dr. Sorry, I can't pronounce your name. Put it, Dr. Jacqueline, that's how Dr. Alasa does it, right? Dr. Jacqueline, put the central away from the spine, Calmia latifolia 330C, and neuropathic central spine is hypericum 30C, right? I got that right?
That's correct.
Okay. All right. We're going to take the world by storm, Dr. Burgess.
This is
Got this.
great.
We got this knocked, right? Dr. Patel, we can't thank you enough
You're
again.
welcome.
It was really, truly a treat and a great, great presentation. Dr. Burgess is next week. Anybody else who wants to present? We're always looking for, you know, our kind of home base here. And, you know, we bring in some outsiders every once in a while also. OMED is coming up. That's our next, you know, big push. And at the moment, we're still on hold as far as our transition to integrative medicine. So I'm doing what I can. The good news is that one of the people on the committee who used to be one of my partners back home in Pennsylvania is now the president-elect of the AOA. So we do have an in there. His name's Ernie Gell. And we actually used to share an office for a couple of years. So hopefully we'll be able to twist some arms, I guess. That's the only way we're going to do it, be able to get this done. So I was hoping to get it done so we could advertise ourselves before OMID, but I'm doing what I can. Okay, anybody have any questions, comments, complaints, fashion tips?
Thank you.
Lottery numbers. If not, we will see you again next week, same time, same station. Dr. Burgess, I
Thank you.
expect you to be ready. Thank you so much.
Thank you all.
Thank you,
Good
Dr.
night.
Patel.
Thank you, Joe.
Excellent job, Dr. Patel. Thank you.
Thank you.
Good night, everybody.
Good night.
Good night.
Aye.
Dr. Block, thank you.
My
And,
pleasure. Thanks for letting me squeeze in at the end there.
Anytime. And Dr. Fogarty, thank you. And thank you for your testimonial. We're going to put that up on our website. We're going to use it in our flyers, if that's okay with you.
All right. Yep. But you can't legally say Dr. Fogarty.
Well, we will just put Marie F. Okay.
Yes.
So just what I'm saying. So
I don't care about the
They're
Fogarty,
not-
it's the doctor.
They're not Dr. Fogarty.
There you go.
Sent me an email earlier today, and she wrote, I sent out 7 invites. I hope some of them show up. I quote, I think it's the most exciting medical event I've seen in my entire lifetime, and I'm 77 years old. I suppose that's not something you should say out loud, though. I'm assuming it's the 70.
You just did.
That's
Takes a
okay.
lot.
We're all there. It used to be old, but it's not anymore.
No, but my mom was 29 forever, right?
Yeah, I know, mine too. Okay, well, thank you so much, everyone. Brad, thanks for being with us, and we'll see you again all next week.
So
Good night.
you may want to send me Dr. Forsyth's contact info, please.
I will send it to you. Okay.
Thank you. Good night.
You got it.
No.
Great. Right.
Bye, Doc.
Right.